that rheumatoid arthritis is one of the most prevalent diseases in the community, and 80% of the patients are disabled 20 years from primary diagnosis of rheumatoid arthritis. Approximately 50% have decreased in the rate. There's been a 50% decrease in the rate of hip and knee surgery since the improvement in the medical therapy, but still, it's the third most common indication for lower limb joint replacement, even in Europe and Northern America. And as we all know, these patients tend to be younger than their counterparts, the osteoarthritis group. Nearly 17% of the patients need some orthopedic intervention within the first 5 years of initial diagnosis. Over a third of these patients will need major joint replacement. And this topic is all about summarizing what's new in this critical area of orthopedic surgery. Again, nothing's more important than preoperative assessment for handling these patients. These are not only localized problems, but they do tend to have significant other systemic involvements that can affect your surgical outcome. For example, cervical spine involvement may affect the type of anesthesia you choose. In a thorough assessment of the condition, as these patients, nearly 80% of these patients have some cervical spine involvement, and in fact, a third have instability of the cervical spine, even subluxation. So a CT scan should be done if they have some symptoms as listed here to include the preoperative assessment. Again, a thorough assessment of all other parts our body, including joints, their drugs, history, examination is critical in planning a good preoperative assessment. When coming to the immunosuppressant, if the patient's been on long-term steroid, usually what we do is taper and then get them into the surgery. But if they have been in long-term, then one must keep in mind Addisonian crisis that can happen during the procedure. Again, use of steroids in preoperative procedure for other general surgical procedures have shown to be increased risk for infection, but there's no published literature on arthroplasty surgery. When coming to the methotrexate, studies have shown that in fact they are not harmful and may even aid in post-operative recovery. But about the new targeted immunotherapies such as TNF-alpha antagonists, there's very limited evidence, and every surgeon has their own choice. But mostly, even me, I tend to discontinue them before surgery. Again, about the surgical sequence, usually it's been shown by Wilkinson based on the biomechanics of lower limbs that forefoot following hip, knee, hindfoot, and ankle surgery in that sequence should be taken to achieve optimum outcome. Again, significant deformities should be considered first, even in the ankle area, and any joint stiffness, contractures should be optimally addressed during surgery. And again, CT scan is a very valuable tool in planning out the alignment and sequence of surgery. Coming to the total hip replacement, obviously there are technical challenges that are very unique to rheumatoid arthritis, including bone loss, osteopenia, problem of protrusion, and because of the osteoporosis, these candidates are usually not suitable for hip resurfacing, but are more suitable for total hip replacement surgery. Choice of the implant, cemented versus uncemented, still a debate, with some studies showing that cemented are better. Well, some studies showing that uncemented proximally circumferentially coated stems tend to have better outcomes. Recent study by Boss have shown that even short stem designs have been successful only for midterm follow-up. No large long-term follow-up data is still available on this. Coming back to the problem of protrusion, we all know it's a problem with rheumatoid, and there has been a various classification system. I find this one very handy, with usually grade 3 is in the area where they need some kind of excess procedure like bone grafting, but it's essential to restore the center of rotation to the teardrop while doing a good hip replacement in these patients. Again, improving cement fixation by drilling holes around the periphery of acetabulum and putting cement directly on the floor graft during insertion of cup. These are some of the other techniques, and more extensive bone loss may need even a cage and additional bone grafting. Coming to the total knee replacement, same problems: poor bone stock, avascular necrosis, deformity, contracture, and one of the main other concerning things in these patients is the ligament issues. The ligaments are not very strong, and we all know total knee replacement is basically a ligament balance surgery rather than a bony surgery, and achieving a good balance is essential. So studies have shown that PCL sacrificing implants may be the preferred ones, but still there are surgeons who do this with PCL retaining prosthesis, but increase in stability with PCL retaining designs have been shown by various studies. So you gotta be careful while doing this. Again, choosing cemented versus uncemented. Again, with poor bone stock and everything, I think cemented is a better option. But again, there are some studies showing that even uncemented TKRs have been shown to have good results. But for me, I think it's always cemented. Few points to consider: significant valgus deformity and ligament issues. Yeah. It's always good to use a constrained design, but we have to be careful not to overstuff, which may result in mid-flexion instability. With fixed contractures over 30 degree, your threshold to do a more constrained design should be low. Coming to the toe ankle replacement, again, it continues to be a poor option when compared to their counterparts that have total hip replacement TKRs. Results are not that as good, and failure rates are still very high. About 85% survival rates have been documented with a study by Jensen. However, mechanical loosening continues to be a major cause of revision. Again, big varus or valgus deformities around ankle, not a good surgical candidate for total ankle replacement. When coming to the revision surgeries in this patient, there's very limited data at present on revision THR. An outcome of cemented revision is proven to be inferior to their osteoarthritic counterparts, and uncemented design is further worse. When coming to a revision of total knee replacement, high failure rates have been reported. Still continues to be a challenge in these patients with continued loss of bone and osteoporosis. Even mortalities has been reported to be higher in this patient, in patients who have been treated for infection. Rehabilitation, these patients tend to have a longer hospital stay with slower functional improvement. But there's no difference as regards to simultaneous or stage bilateral knee replacements. These patients are always a high risk for complications, and it's been shown by various studies. Periprosthetic fractures tend to be more common. Again, osteoporosis is a major contributing factor to that. Infection is higher considering their immunosuppressive drugs and overall diminished resistance to infection. But as regards to thromboembolism, there's still not been proven literature that says that it's 100% risk. Some studies do suggest that it's an independent risk factor for pulmonary embolism and deep vein thrombosis. Patients with active disease and raised rheumatoid titer, clinical depression tend to do worse. There's been higher readmission rates for infection in these patients. A number of studies showing that. Residual pain and poor improvement in functional outcome is there as compared to their osteoarthritic counterparts. In conclusion, rheumatoid arthritis is a systemic disease and needs a thorough preoperative optimization. Continued use of methotrexate is recommended. Biological agents like TNF-alpha antagonists should be stopped, as there is no current data supporting their use during the surgical procedure. And surgical sequence, hip, knee, ankle, cemented designs have been superior, and the need for bone grafting should be identified during preoperative planning. When it comes to total knee, PCL sacrificing designs may limit early instability and potential revisions. And as regards toe ankle, the results are still inferior as compared to the toe hip and toe knee. Thank you. Any questions?
No.
For distal radius fracture, this is an interesting topic. I wanted to love to talk about this topic. And previously all distal radius fractures roughly mentioned as Coley's fracture. The treatment used to have manipulation casting, as classically described by Dr. Abraham Coley's. He mentioned that fracture would heal with deformity, but the functional deficit would be acceptable. However, today is not the same, and we have better understanding. Various classification systems based on mechanism of injury, based on joint involvement, all helpful to identify how these fractures are in depth and guiding their treatment. So the method of treatment should be based on a careful study of individual fracture pattern in these days, and the fracture union is no longer the only goal, but we do have to restore the anatomy and get the functional recovery as soon as possible in the form of full and painless motion of the wrist. There are patient-related factors that affect the choice of management in managing these fractures. Age greater than 65 years have higher risk of secondary displacement. Risk of failure to maintain reduction is more in patients greater than 60 years. And again, age is an independent predictor of late instability and malunion. So higher the age, more chance of late instability and malunion. But it's been a recent thing that older patients are more tolerant of radiological malalignment, and functional outcome may not correlate with restoration of anatomy. There's been newer studies now coming up that's popped up a recent controversy in managing these fractures. Again, when dealing with the patient factors in managing these fractures, osteoporosis is again a critical determinant, and patients with osteoporosis dorsal combination tend to lose their reduction with non-operative treatment. Work-related injuries, again, I think it's everywhere the same in orthopedics. Injury compensation is a predictor of pain and disability in this fracture. Patients with work-related injuries are less likely to return to work, so you got to be very careful in dealing with these patients. When coming about the fracture characteristics affecting choice of management, the predictors are initial displacement, so greater than 1 centimeter displacement, radial shortening greater than 5 millimeter, presence of metaphyseal combination, intra-articular fractures, incongruity. All these fractures tend to do worse and better managed with an operative intervention. So treatment-wise, non-operative treatments can be done in patients with undisplaced fracture, well-reduced stable fractures, old age, low-demand functional patients. However, the concept of this form of treatment is cumbersome CAS, compartment syndrome, rarely, median nerve neuropathies, and loss of reduction, obviously. Closed reduction casting basically is based on principle of ligament tutaxis, where indirect reduction is achieved with the help of traction on the ligaments. Usually deformity is first exaggerated and then reduced. Basically the mechanism of injury is reversed to achieve a good reduction, but it's critical to achieve a 3-point well-molded cast to maintain the reduction in these patients. However, points to remember when treating distal radius fractures with non-operative treatment: no control on intra-articular fragments without any capsular attachments, the quality of closed reduction and the likelihood of redisplacement is very crucial whether to decide not to operate. In young patients, your threshold should be low, and fracture displacement happens, you should straight away go ahead with operative intervention. In elderly patients, though, you can't tolerate a little bit of displacement. Again, surgical treatment is essential to first identify how the fracture is with the help of CT scan, but still there is no universal consensus, whether which type of surgical method should be used, and we are still dealing with, the optimum surgical treatment for these fractures. These days we all talk about cutoffs. There's no exact, studies guiding all these. This is just a general guideline which I follow, and most of the surgeons I have been trained or working with my colleagues, they follow regarding maintenance of the alignment while achieving treatment for these fractures. Goal of surgical treatment is the same everywhere. AO principles: restore and maintain anatomy, early mobilization, minimal risk of complications. So coming to plate fixation, it's been increasing these days, and with availability of better designs, the new locking constructs, I think this is getting more and more trendy in surgeons. Again, indications: unstable fractures, intra-articular fractures, delayed fixation, patients needing earlier mobilization, obviously young patients. These are all candidates. But we all know the disadvantages of surgery, scar, infection, tendon ruptures, implant cost, surgeon cost. So this has been a real debate these days, with more newer studies coming up, which I'll talk about later. Plate fixation, again, volar approach is getting universal with newer designs, but very rarely one may like to use a dorsal approach for obvious reasons when we cannot achieve good reduction with volar approach. So there's been good evidence now which suggests that open reduction internal fixation is a good choice of treatment as regards to percutaneous pinning and casting. However, this is all early functional follow-up, and many studies fail to show eventual long-term good outcome with when compared to the other groups. When talking about the external fixation for fracture fixation, again indicated for patients mainly with highly comminuted intra-articular fractures, poor soft tissue condition, and usually as an adjunct to internal fixation or pinning. There are types of external fixator. I don't want to go in all that detail, but basically this is an option for fractures which are badly comminuted. Again, pin track infection, tendon injuries, nerve injuries tend to be an issue with external fixation, but this is a good option for patients with poor soft tissue. Again, evidence suggests it's obviously better than conservative treatment, but higher rate of minor complications, though the serious complications like RSD is same, both non-operative versus fixation. Now, pinning, this is a hot topic these days with a recent study by Tubeoff in 2015. It's basically a trial-based study which showed that KOR fixation is no different than internal reduction and plate fixation in patients with extra-articular displaced fractures, but it's very economical. So that's the whole debate, and I think the insurance company is going to catch up on this, and it's going to be an issue. But again, closed reduction percutaneous pinning is obviously a good option in patients with without significant combination. It does suggest improved outcome as compared to casting, but you know, it's did not necessarily translate to improved functional outcome. The outcome that appears is an anatomical outcome, which is better when compared to casting. Coming to the adjunct methods, one may need to use bone graft, artificial bone substitutes, again depending on fracture impaction, delayed surgical treatment, osteoporosis, and the recent debate that we had a few years ago about vitamin C, with some studies showing that's very useful. More recent studies shows that it makes no significant difference. These patients will need definitive rehabilitation, physical therapy, and follow-ups, and favorable outcome have been reported with systematic physical therapy and exercises. But the key is early mobilization with stable fixation. Thank you.